Good morning. I appreciate that. We're about to start our second panel today. My name is Garrett. I am Congresswoman Kelly's Chief of Staff with the CBC Health Braintrust. We're honored this is our first year doing it. We're honored to be working with the National Minority Quality Forum, Dr. Puckrein and Gretchen. So this panel that we're going to discuss is going to be the national agenda to reduce diabetes-related hospitalization in biodiverse communities. We have a very strong panel. Many of the folks on this panel you know, such as Dr. Puckrein, who obviously at this point needs no introduction. We have Mr. Brent Egan, who is a professor of medicine and pharmacology at the Medical University of South Carolina. He received his medical degree and training in medicine and hypertension at the University of Michigan. His clinical and basic research examination of mechanisms of cardiovascular risk in obesity and suggests that fatty acids participate in pathophysiology of the metabolic syndrome through various pathways. His group is currently examining the effects of the DASH eating plan on oxidative stress in metabolic syndrome patients. Mr. Egan. Next, we have Coletrane Stansbury, MPP. Coletrane Stansbury manages a portfolio of projects and initiatives that support Johnson & Johnson's global diversity and inclusion strategy. His responsibilities include leading Johnson & Johnson's national program designed to address childhood obesity, the gateway to a healthy community. He supports D&I sanction leads in developing and implementing action plans aimed at advancing strategic diversity initiatives and assisting D&I sector leads in conducting analysis and evaluation of key driving diversity results. Mr. Stansbury. Then finally, last but not least, we have Lisa Valtierra. Lisa Valtierra's years of experience in the pharma patient advocacy arena has aided her in her current focus on cross-cultural marketing, concentrating on the U.S. Latino population. She works across therapeutic areas to assist brand teams in incorporating Hispanic markets in their overall strategies, developing in-language and culturally relevant and resonant campaigns. Her work entails ensuring appropriate resources for projects that integrate with general market strategies, as well as raising awareness for the need to create campaigns that reach diverse audiences. Ms. Valtierra. We're going to go ahead and start with the presentations. Each presenter will present for roughly 10 minutes, and I'm going to go ahead and start with Dr. Puckrein. Dr. Puckrein.
Good morning again. In the interest of time, I'm going to keep my remarks brief. So we've done a lot of work mapping diabetes to the zip code level. So if you go to our website, NMQF.org, you'll be able to pull up a national map of diabetes. Just some quick numbers to grab a hold of. So there are 38,000 zip codes in the United States where people live. 70% of African Americans live in 2,500 zip codes. So the conversation that we're having about health disparities is really a conversation, insofar as African Americans are concerned, is a conversation about 2,500 zip codes. About 50% of Hispanics live in 1,500 zip codes, and about 50% of Asians live in 1,500 zip codes. So when we're talking about disparities in minority populations, we're talking about 6,000 zip codes. When you say it doesn't sound like a big number, it doesn't sound like an incredibly difficult number. But in those 6,000 zip codes, as I said earlier today, 38% of the adult population has diabetes. When you look at, in those 6,000 zip codes, 2,500 that are African American, 40% of African Americans with diabetes have a hemoglobin A1C above 8. 57% of Hispanics who have diabetes have a hemoglobin A1C of above 8. What that's signaling to us is that the quality of care, the adherence to clinical guidelines are not being met in those 6,000 zip codes. And the other thing I would call to your attention as we're talking about health disparities, let's really understand what we're saying. We are saying that there is a systemic and systematic output from those 6,000 zip codes that keeps the diabetes prevalence at 38%, highly predictive. And I use the word highly predictive to say to you that when you look at those 6,000 zip codes, the number of new cases of diabetes, newly treated cases of diabetes, doesn't vary very much from one year to the next. You can look at those 6,000 zip codes and tomorrow say, next year, here are the number of new cases of diabetes in those communities. And if you're looking at the trends, wouldn't vary much, 1, maybe 2% on mark. What I'm also saying to you, when you look at those 6,000 zip codes, that the number of acute events, the number of hospitalizations, what percent of that population went to the hospital this year and next year wouldn't vary very much year to year. If you look at mortality, which is even scarier to me, because what I'm saying to you is, you can look at those 6,000 zip codes and predict with precision how many of those patients are going to die with an underlying condition of diabetes next year. Emergency room visits, predictive. You can absolutely count the number of patients who are not only going to visit the emergency room, but you can predict how many of them are going to have an inpatient stay as a result of that emergency room visit. I can also tell you that about 67% of newly cases of diabetes gets diagnosed in the emergency room. So if you're looking at the numbers and you're focused in on those disparate populations, it's a numbers game. And what we're really talking about is not do we have the capacity, because we've got that, the question is, do we have the will, the interest, the inclination to break those highly structured patterns? That's really what this conversation is about. So one of the things that we want to do at the National Minority Equality Forum is that we want to own that. I have staff say, you don't want to own it. No, we want to own it. We want to own it. We want to own it. Yes, we want to own it. Because you can't look at the numbers and those predictive patterns, which we've published, by the way. So we're talking about stuff that we've put in peer reviewed. And walk away and treat it as an academic exercise. That's not what we're about. So we're really lucky. I told her I was going to call her out. Deanne Staley here. She's coming aboard to help us reduce avoidable diabetes-related hospitalizations. And I give credit to Bruce Taylor back there. He said the way to tackle that is 5 by 5, 5% over 5 years. Something we can do in those 6,000 zip codes. So that's the conversation we want to have with you, because many of you live in those zip codes. You live next door to people who are on their way to the hospital, going into the emergency room. These are your neighbors. These are people in your family. And so we don't want to sit here now and I'm giving you a recitation of the numbers, but that's not the exercise. The exercise is, can we partner? Can we collaborate? I'll finish with this. The Office of Minority Health in Oregon, several years ago, had a beautiful insight on their website that I've really taken to heart. And basically what it said is, healthcare and living is a collaboration. It's a community act. I know there's a tendency to think that we can do it on our own, but the fact of the matter is, it's a communal act. And in those 6,000 zip codes, we have to come together as a community and sort of figure out next steps. So what we intend to do at the end of this summit and some of the other panels, we're going to e-blast you and say, we'd like you to be part of one of these alliances. Think about it. Join with us, partner with us, because we want to own it. Yeah, we want to own it. We want to take responsibility. Blame us. Because if we don't do it and you don't work with us, we're at fault. We have to own it that way. Thank you.
Good morning, I'm Brent Egan. I'm going to talk a little bit about some of the work we've done and looking at some other databases, so if we could have those slides up for a moment here. Showing you some of my disclosures. And I'm looking for the slide advance. Do I have that there, or you control it from the back? It's here? Oh, I see it now. Thank you. I want to go through just a quick overview of the next few minutes. We'll talk about the social and medical determinants of health outcomes, where the lion's share falls on that social side, which includes economic and place-based differences. Diabetes clearly becoming more common in minorities. We'll look at that and some of the risk factor control patterns, and also where we're headed as a nation. You've heard some of that. I'd like to put a couple of slides to that exactly. And then talk about adults with diabetes who really have multiple chronic conditions, and it's a very rare patient with diabetes that doesn't have at least one other major chronic condition. And then we'll look at an integrated approach to addressing social and medical determinants. So this is from the Institute for Healthcare Improvement, looking at a model for health equity. And you'll see socioeconomic, behavioral, genetic, a number of factors on the left side, which account for about 80% of the variance in health outcome. And so much of that disease, those chronic diseases are in place, and as Dr. Puckrein said, being diagnosed at the emergency department level before people actually get into the healthcare system. We do have an obvious opportunity to impact disease progression and outcomes at the medical side, but if we're going to be successful in creating health equity, we will never have health equity as long as we have major disparities in prevalence of chronic disease. And right now we have major disparities in prevalence of chronic disease. You've seen this slide previously. Edward Deming, who's sort of the father of quality improvement, said we're perfectly designed for the results we're getting. We're perfectly designed as a society to generate obesity, diabetes, and a host of chronic diseases. If we want a different result, it requires a radically different design. Modern life does have its conveniences, but also its costs. And I realize that these diseases disproportionately affect minority and low income, but I would say in this country, too many of us have access to excess calories, sugar, fat, salt, labor-saving devices, and passive entertainment. Wherever that exists, you get an avalanche of chronic disease. Healthy people in healthy communities, easy as, not really easy, and we know that, but all of the discussions we have around healthcare and 20% of our national economy dedicated hopefully to three things when it comes to health. How do we promote healthy lifestyles in all communities? How do we ensure timely access to and adherence with evidence-based care? And I think very importantly in terms of the social fabric of our country, as Solomon said over 2,900 years ago, a heart at peace gives life to the body. People are also born with a need to be part of a community of love and have a life of purpose. And I think too often in our country we devalue people and we don't acknowledge that essential worth and their purpose in life. And I think that's fundamental to health equity. As already been said, the face of America is changing by the year 2050. We will not have a majority population as we've known it. In fact, the majority population will be minorities, with nearly 30% Hispanic, 13% African American, and 9% Asian. In a culture that's designed very well for producing obesity and chronic diseases, it turns out that these current minority populations are at greater risk of access to excess. What you're looking at is waist circumference, and notice it requires a larger waist circumference for whites to have the same risk of diabetes as all of these other groups. So we've got a culture that's designed access to excess to generate obesity, and we're having increasingly populations that are actually greater susceptibility to that access to excess when it comes to generating diabetes. Not surprisingly, in the U.S., we have these disparities around prevalent diabetes, with non-Hispanic whites on the left, Hispanics and non-Hispanic blacks on the right. Within the Hispanic population, we have groups that look more like Caucasians in terms of Cuban and South Americans, and those that look more like the non-Hispanic blacks in terms of Mexican Americans and Puerto Ricans. So it turns out that probably not all Hispanic Latino populations share that same risk, but there's nearly a twofold difference in prevalent diabetes within the Latino Hispanic population. Dr. Puckrein mentioned by zip code. You can also look at the county level, and those darker red counties are those with the high prevalence of diabetes. And with so many things, you see the southeastern, southern part of the U.S. being at greater risk. But obviously throughout much of our nation, but there is certainly these concentrated areas of diabetes which disproportionately are our minority populations. What I'd like to do is to take a look with you at not only these adults with diabetes and multiple chronic conditions, but also begin to talk about an integrated approach. In terms of an integrated approach, the Steno study from Europe with 160 patients, 80 randomized to conventional care, 80 to intensive therapy, where they managed the multiple risk factors, the diabetes, the hypertension, the lipids, the coagulation problems with antiplatelet therapy. And within about 8 years, they cut the rate of major complications by 50%. So it wasn't just managing the diabetes, but a multifactorial approach to managing multiple chronic diseases that produced a dramatic improvement in major outcomes. This was cardiovascular. You could look at the kidney, you could look at the eye, but intensive management of multiple risk had great benefit. Now, there's a lot of data on here, but I want to summarize it down so it makes some sense. On the left-hand side, you have individuals under the age of 65. On the right-hand side, you have individuals 65 and older. The first cross-hatched bars are Caucasians. The middle bar is African American, and the right is Hispanic. Notice that under the age of 65, the top bar, that Caucasians had the best diabetes control in 1999 to 2004, did not change much to 2005-10, but remained higher than in the younger blacks and Hispanics. Notice that none of the young groups did particularly well in controlling their cholesterols. Notice that the younger folks did by and large better in having a blood pressure that was less than 140/90. Notice on the right-hand side that there's less disparities between Hispanics, blacks, and whites. And in fact, Medicare is a great equalizer when it comes to risk factor control. These are cross-sectional and not longitudinal data. The problem becomes that many of these younger individuals, where the disparities exist, have their diabetes longer than the whites do. And a lot of that vascular disease and target organ disease is already baked in by the time they get to Medicare, when the better equity in health care delivery exists. These are data from our Quality Improvement Network. We're working with over 500 medical sites across South Carolina with some 2.5 million patients. These are just the individuals over 65, about 400,000 of them. 86,000 plus have diabetes. 83% have coexisting hypertension, 68%. These are diagnoses. These are diagnosed disorders. Lipid problems, 48% obesity, 27% coronary heart disease, 23% COPD, asthma, arrhythmias, chronic kidney disease, mental health, which is really underdiagnosed, mostly depression, heart failure, cancer, peripheral vascular disease, cerebrovascular disease. So again, these patients with diabetes do not come with a single health condition. We found only 2% of diabetic patients this age did not have another major comorbid diagnosis, and if they had a full medical examination, probably they have comorbid conditions as well. So again, just to move on here, what we see in the healthcare system that I think will change the paradigm is change how we pay for healthcare. The traditional fee-for-service in Medicare, which is that circle on the outside in brown, is shrinking rapidly. Even the fee-for-service is going to be linked to quality outcomes, and within that you have the alternative payment models where pay is definitely linked to the quality of outcomes. That will expand very rapidly between 2016 and 2018, so that in fact the reimbursement for health care, I think, is going to change toward a more integrated and more holistic approach to manage the multiple risk factors these individuals have, so that we have better outcomes. Single disease management programs have not delivered on the promise of better health, lower costs that was anticipated, largely because the majority of individuals have multiple chronic conditions. These clinically integrated networks, remember, it's healthy lifestyles, timely access to effective care and medications, valuing people, having a heart at peace, having purpose. These clinically integrated networks are complex, but it's only in these large clinically integrated networks that we have the opportunity to bring all these pieces together. Clinically integrated networks, by their definition, have to have at least 30% of primary care in a region, which begins to move toward a monopoly. In Greenville, South Carolina, Greenville County, Greenville Health System that I'm part of has 70% of the medical care in the county. The advantage of that, though, is it gives us a major incentive to reach into communities and to address social determinants of health, which drive the majority of variance in health outcomes. I'm not going to go through all the blocks on here, it takes too much time, but to say that clinically integrated networks are complex, they address a couple of basic issues, but in fact a dominant position in the healthcare market with fees for service going and quality coming in gives large healthcare systems a reason to reach into communities, address the social determinants, as well as comprehensive integrated management of complex conditions. But again, health equity requires attention to both social and medical determinants of health, social determinants being the lion's shares of the outcome. So I just want to stop here and turn it over to our next speaker, and trust we'll have a few minutes for questions.
Good morning, everyone. I'm Coletrane Stansbury, and I represent Johnson & Johnson from the Office of Diversity and Inclusion. I wanted to first thank Dr. Puckrein for inviting me to be a part of this. I'm not a stranger to this forum. I presented last year on the Gateway to Healthy Communities initiative, which I have the pleasure of running. And more importantly, I have the pleasure of working for and with children. We know that this is a central theme at Johnson & Johnson. Our care for our customers and those who we serve the most, who are in at-risk and underserved communities. So, just waiting for my presentation. So I'll start without it. So Once again, our program was founded through Anthony Carter, who's our Chief Diversity Officer at Johnson & Johnson, 3 now going on 4 years ago. And the idea was to help combat childhood obesity in the communities that needed to be addressed the most. So we set out with this premise and looked at an initial footprint of 4 cities, now 5, which include Atlanta, Houston, Philadelphia, Newark, New Jersey, and New York City. Those 5 cities, we've now been able to reach extraordinary results. But I wanted to kind of take you through a journey of what those results are and how we got to where we are in this space. I think the important thing to point out is that our program is a school-based initiative. And when we thought about addressing childhood obesity, we knew that we're dealing with children who, unlike adults who can compartmentalize their lives and have sort of the complexity of trying to figure out at any given time based on the will of adulthood where they are and how they would like to be measured, we have this opportunity to be involved in children's lives for at least 8 hours. And so as a school-based initiative, the idea is to make sure we keep kids moving. That movement is somehow combating a sedentary lifestyle. And we know that in a sedentary lifestyle, we're not just merely talking about activity and how activity has a direct correlation to fitness, but all the different aspects of activity and combating a sedentary lifestyle. So in defining sedentary lifestyle, we look at the physiological effects of a sedentary lifestyle, which diseases of excess weight and childhood obesity in particular fall in, bad posture, and poor cardiovascular fitness. We also know there's cognitive effects such as poor student study skills and short attention spans, not just in classroom and during test taking, but just in listening skills in general in community and home and social settings. That there's an emotional effect as well of sedentary lifestyle, which are low self-esteem, depression, and low ability to be motivated to do anything that includes group activity and teamwork. And then the social behaviors of that lifestyle, which are poor family connections, isolation, and antisocial behavior. We know that in looking at this program and the design being around childhood obesity, but knowing that there are all these other effects of sedentary lifestyle, it led us into a space of realizing that what we're really talking about is whole child health. Not just the ability to affect movement and move the needle on childhood obesity from a fitness perspective, but there are all these other indicators that if we only focus on fitness, we're really looking at other areas that can also affect the child, not just in the state of childhood, but for a lifetime. Some of the startling things to understand about the issue is that 22% of U.S. schools don't require physical education classes in their curriculum. According to the CDC, a child who is obese between the ages of 10 and 13 has an 80% chance of being obese as an adult. All these things have terrible effects on a child's ability not only to socially interact, but their self-awareness and their self-concept and their ability to realize positive self-esteem. The overall impact that we want to address with our program are on the same indicators of the issues. So knowing that there is a physiological effect of sedentary lifestyle, we want to create positive aerobic fitness, coordination and balance, and affect motor skills. Cognitively, we want to affect focus and attention, memory, and really tap into a child's creativity. Emotionally, we're looking at stress reduction, self-image, and positive mood effect. And also socially, building those life skills that develop the ability to both in community and social settings realize positive social interactions. With an impact of increased physical activity, improved overall health, better academic performance, increased knowledge, improved teamwork, improved attendance, improving confidence, and then also showing that children have the ability to aspire. The overall strategy of the program is to look at a school to home to community model, where the schools are the beginning space, where 8 hours, as I said earlier, are the initial point of contact for a child, not just as a way to affect through program, but to study really how a child is correlating to academic performance and behavior moods over time. Then looking at the home as a way of embedding even more hours into a child's development, looking at ways with sibling, parents, and caregivers, children are or are not receiving the right and attention around fitness, physical attention, around the ability to look at nutritional opportunities, and what their diets are as it relates going into the evening hours. And then also the community. How are community values being affected, and how are children learning in a community setting to create positive values for a lifetime? With this, we designed and created a tool, ActivityWorks. ActivityWorks is an in-classroom solution that is both multi-sensory and has the ability to be measurable over time, where for 10 to 12 minutes per episode, as we call it, a child is immersed in this audio-visual experience where they are being taken through the wonders of the world, through the rainforest, through different space adventures, where they are learning and they are being tapped into a curricular-based initiative, but they're also moving at the same time. Each 10 to 12-minute episodes burns about 100 calories. So when we aggregate that over 5 cities and we look at our full footprint, which includes about 192 schools, 3,300 classrooms, and 240,000 students, to date they've burned about 530 million calories. And with that, we're looking at about 2.5 million cardio hours utilized. When we stretch that out and we talk about this in terms that both adults and children can understand, we're looking at about 8 trips to the moon and back. That's a lot of steps. That's a lot of progress. Dr. Sagata Mitra spoke, who won the TED Prize last year, about a hole-in-the-wall experiment, where he created an opportunity for children in rural India to experience, free of charge, with no bureaucracy, no classroom, no walls, access to free internet. And he thought of this idea that children could learn minimally without invasive or intrusive ideas of what school and learning could really be, but having access to an imaginary space where they could see themselves and have access to the possibilities of what it could be to take ownership of their own life and lifestyle. With amazing results, these rural Indian communities found reason for not just looking at social media and checking internet and YouTube, but learning and finding spaces with other children in other places of how to improve their own life. In many ways, our program is doing the same through a laptop or through a smart board in a classroom. In urban America and rural America, a child can, for 10 minutes a day and recommended 4 a week, have access to information, but also take ownership in a non-threatening environment of teamwork, anti-bullying, and self-confidence, explore who they are, explore curriculum, and take charge of their own health. I also wanted to bring, in closing my presentation, attention to some of our values moving forward. Knowing that our first few years we're really trying to set in terms of creating the first initial footprint and proof of concept of our idea. Moving into last year, finding ways to digitize more content with our relationships with Microsoft, who gives us access to the cloud system and the Azure platform. So children in our whole footprint can access free internet and upload for free. We also now are looking in year 4 and beyond at 2 things that we're challenged with by Alex Gorski, our chairman and CEO, to do. Number 1 is deeper levels of measurement. How do we go beyond usage data, which tells us the prevalence and how efficiently and effectively we're moving? But now how do we go deeper into measuring BMI and waist circumference and find ways to use wearables, for instance, as a way of tracking children in the classroom at the individual level, de-identified, but also at home so we can extend the level of research. And then looking outward with that research, not just year by year, but 3-year studies to follow a child's development in the program into their 4th, 5th, and 6th grade years. So with that, we also look at the last sector that we want to study, and that's going forward into deeper levels of content. And how does content drive behavior change? Giving children access to deeper content means having mobile devices. We're working now with Microsoft to create and put in the hands of caregivers and moms free cell phones in our footprint, so that those smartphones can have access not only to the ActivityWorks platform, so kids can, through avatars, extend points and rewards at home for doing healthy activities, but also moms and caregivers can receive text messages and interact with school nurses, for instance, around immunization needs. And they can access other healthy J&J apps such as Text for Babies, where moms can, through different levels of pregnancy, have access to healthy information. So these are all ideas that creativity creates innovation. Innovation can validate a program, but more importantly, we can connect with children in a disease state early, create prevention, but also education, and create a type of lifestyle around children where they can be empowered to take access to their own health and learn ways in peer-to-peer, as well as school to home and home to community, create the right connections young in life that they can feel empowered to be leaders of their own health. Thank you so much.
Good morning. So it is a great pleasure for me to be here. My name is Lisa Valtierra. I work for Boehringer Ingelheim Pharmaceuticals. And I'm presenting to you a program called Cuida tu Don de la Salud. And it is a program that was kind of a very personal win for me, because I think, as you all know, the pharmaceutical industry is not great at reaching out to communities of color. And this has been a passion of mine since I started years ago in HIV advocacy in Los Angeles, knowing that from the advocacy side and from the patient's perspective, pharma companies do not really know how to engage with people. And I feel very strongly that until we engage with people at the heart level, we're never going to really get them to move on their health. So I have the power here to move the slides. There we go. So the situation for BI was that we started building a presence to the U.S. Hispanic population, and historically the company had never really done this on a sustained level. And so in 2013 we did a small kind of proof of concept to see if we could actually engage with the U.S. Hispanic population. Well, that was a successful effort, and so what we need to do was continue building on that, because we didn't want to just start and then stop and start and stop, because that again just leaves people confused and annoyed. So what I wanted to do was leverage what we had started and grow that opportunity. So we developed something called Cuida tu Don de la Salud, which means take care of your gift of health. Because I really believe that using the insights of the data that we had gathered, Hispanics, actually nobody looks at their health as something separate from themselves. And playing on this idea that health is a gift, and the word don actually has two meanings. It means gift, and it also means, it's a term of respect. So such as, well, if you remember the Godfather movies, Don Corleone. Don is like saying sir. So we asked Don Francisco, who is an iconic figure in the U.S. Hispanic entertainment world, to be our ambassador for this program. And the objectives for the program are to engage, educate, and inspire the U.S. Hispanic community to take care of their health. And in order, using that word don, that gift, we also want them to realize that they have gifts every day that they're sharing with their families and loved ones, whether it's the gift of being able to play music or cooking or singing, whatever it is. They can't continue sharing those until, if they're in poor health. So we also wanted to encourage our audience to proactively seek and act on health information, because I think we can all pretty much agree that there is very little information that's accessible in Spanish. So this whole program is created in Spanish for Spanish speakers here in the U.S. And we also wanted to continue building the presence that the company had built back in 2013. So it's a very comprehensive program. This is a busy slide, and I'm sure that if you have your smartphone, you can probably go to cuidatudon.com and really experience the program for yourself. And I do remind you that if you don't speak Spanish, it might be a little bit confusing, because this is geared for Spanish speakers. But we started out with some advertising on TV, on Univision. We had some integrated vignettes that were talking about type 2 diabetes, and we're focusing on diabetes simply because that is the largest prevalent disease among Hispanics, and it gave us kind of a way in. We do hope to expand this program to other disease states, but it made sense for us to tackle diabetes first. We also have flyers and posters that can go in physicians' offices and in hospitals. We have a mobile presence, so the whole site is already mobilely enabled, because 92% of the people coming to Cuida Tu Don are coming through mobile devices. 70%, or actually 80% through phones, another 10% through tablets, and the remaining 8 to 9% via PCs or laptops. So that tells us that this whole community, across age ranges, across socioeconomic spectra, are coming through mobile devices. So to create something that isn't available via mobile is pointless. So we made sure that we wanted to include that. We also reached out, and I think this is a first for our company. We made the assets on the website available to hospitals in large Hispanic areas, because we wanted to bring this tie in. So Don Francisco, if you don't know who he is a hugely popular man, and he just announced his retirement from a show called Sábado Gigante, which has been running for 53 years in a row. And he resonates with people. I mean, they just love him. So having him as our spokesperson and offering, you can see this cutout of him holding a sign. That's actually a life-size cutout that we've made available to any hospital that wants to put it in their lobby or in their diabetes clinics, because people see him and go, oh, yo conozco a Don Francisco, me amo a Don Francisco, crecí con Don Francisco. I grew up with him in the house. I mean, it's one of those things where people just like, Don Francisco. He's like Oprah and the Pope rolled into one. So using him as our ambassador, as he calls it, really resonates. And he also has type 2 diabetes, and he talks about it. So when people come to the site, they can opt in to receive monthly emails, they can opt in to receive texts, and we've just implemented polling via text. So we ask them questions about type 2 diabetes. What are they understanding? So now we can start to gather information on where their knowledge gaps are, and that will also help us add more content in the future. It's mainly video-based, so people come on the site and they see videos, some with Don Francisco himself, others that are very brief, giving expert tips from a nutritionist, a physician, and a exercise specialist on small things that people can do to take care of themselves. All of this is to keep them engaged. Every month we're adding more videos so that they keep coming back, so that they can learn in simple ways that are culturally relevant. And that is my biggest win here, is that these things are culturally relevant. We're talking about the foods they eat, the way they interact with their family. We're engaging caregivers as well. You can see the cutout. This is the Adventist Health in Los Angeles, White Memorial in East Los Angeles. They happen to have a 92% Hispanic population that they serve, 70% of whom are living with type 2 diabetes. So this asset that they can use for free. They can use the videos in their intranet monitors. They can post the posters there, and they're getting people to come back to the doctor because all the information is telling people, talk to your healthcare providers, stay engaged with your providers. And so all of these things are proving highly popular. These are some metrics from the first 3 months that we rolled out this program. And as you can see, if you can see on the bottom left, average click-through rate is 0.95. The pharma standard click-through rate is 0.08%. So we can tell that people are going, wow, I need this information. Sometimes people text us back saying, gracias. One woman said in Spanish, I need to lose 100 pounds, what do I eat? So we can tell that we are hitting them where they need to be reached, and that is hugely important. We are growing the program. We will be continuing this indefinitely, so this is not kind of a one-off typical pharma campaign. This is meant to stay so that it becomes our platform to engage U.S. Hispanics. And I will end there because I'm sure there are questions and people are probably getting hungry and getting ready for lunch. Thank you.
All right. I don't know how I follow the Pope and Oprah, but we're going to go ahead and have questions from the audience. If you have questions that you'd like to ask our panelists, please step to the microphone. All right, seeing none, I guess I'll start with my first question. I was wondering, I know that Mr. Stansbury, in your presentation, you spoke a lot about how to engage young children and from the elementary school age. What about adult populations that we see that are the folks we see more so in hospitalization?
Sure. Well, with the Gateway to Healthy Communities initiative, as we talked through the model of school to home to community, the whole idea is that with every child, there's some caregiver at home who is affecting that child's health, their state of health. And that can be through not just home habits as it relates to sleep habits, for instance, the stress that is on a child at home, but also in terms of nutrition. And with our program, we have to be very careful because with nutrition specifically, there are cultural sensitivities that we have to have around what a child eats. It could be related to a type of tradition, not just in terms of cultural traditions, but religious traditions as well. And so with that, we want to make sure that there is a wholesome message, a universal message, but more so the message is the child, him or herself. The fact that they're coming home empowered and energized and understand better healthy habits such as better sleeping, positive behavior, and excitement around doing homework, that leads to empowering an adult to make a different decision indirectly.
And then, Lisa, you spoke about the various markets that you guys are in. I saw that New York, Los Angeles, and Houston were your top 3 markets where you have people involved.
Right.
I didn't see Chicago on there, so I have to figure out how to improve that. But what are you guys doing there?
What we've done is we've empowered our field force, so some of our salespeople and our field personnel who deal with managed markets, so large hospital systems, and we've asked them to identify hospital systems and hospitals and clinics that have a large Latino population, because where there's a large Latino population, there's going to be a large diabetes prevalence. And so we're giving them these assets to take to those communities. We started in LA, Houston, New York, and Miami is kind of, let's see how this goes. And so we could get feedback, and now I've been able to work with the internal teams and say, okay, now you can run with it because people really do like it. I didn't want to give them all a charge to do something and take people's time if it wasn't going to be popular or well received. So the feedback we've been getting from places like White Memorial in LA is, wow, we really need this because the quality is something that they could never afford to do on their own. So we're creating this more of a synergistic and giving them kind of a value add had. You know, pharma is always known for just we're pushing medications, but we recognize that it has to be a collaborative effort, and we can help them reach their goals, especially with ACA and being paid for outcome. You know, here are some assets that can engage their populations as well.
And one thing I think that we all do know is that most minority populations, and while we're at the bottom level, a lot of things, we're over-indexed in things like app usage and social media. So platforms where we use those two resources are usually hit our communities a lot quicker and a lot more efficiently. Dr. Egan, I know that you're the physician on the panel, and you're also a professor. When you bring these your results of your study to your students, and you doing your research here, what is the thing that they're most shocked by, and what else do they think we can do to better improve from a physician standpoint?
Well, one of the things I'd like to say is, you know, I have a chance to talk to quite a few medical students and interns and residents, and I see in our country, I think, a greater sensitivity to the health disparities than I've seen perhaps in previous generations. It may be that they realize that their peers are changing and that we're a more diverse culture, but I think there's a real interest in serving and particularly not seeing the economic incentives as the be-all and end-all. I think they're also interested in a more holistic and integrated approach to health, and realizing that it does require, you know, healthy lifestyles, good relationships, in addition to good medical care. So I'm actually optimistic as we look at our healthcare force of the future that we're moving in the right direction. I think our healthcare force is becoming more diverse as well. So I think those are some real positives. I think within that, particularly healthcare today is very challenged. I mentioned we have an aging population, which we all know, but one in which there are more chronic diseases and combinations. So in a way, we're moving toward a society that's going to require more complex healthcare moving forward. So I do think that what I'm seeing is a change in our healthcare force, a greater sensitivity to diversity, less focus on money and more on service, and one that realizes that we must have this integrated social, behavioral, and medical approach, a more integrated and holistic approach, one that recognizes faith and preferences and community that I think is actually an exciting part of the future, but recognizing also that if we don't begin to deal with the burden of chronic disease, I think it's going to be even difficult for that healthcare of the future to manage that. But again, very positive about our developing healthcare force.
Thank you, sir. We have a question from the audience.
As usual, yeah, Asian, I hate to stand up. Anyway, so it is a comment, and that as I share with you the events, when we first started, the meeting, that for us as an Asian group, that we have been recognized, by the American Diabetes Association about the linkage of the Asian BMI with diabetes and other cardiovascular diseases. So just a reminder that about that correlation, that specifically listening to your presentation, that there's a 68% of hypertension as a comorbid, with morbidity with diabetes. So it could also explain how in the Asian population we do have a high rate of hypertension with going into a stroke that might be linked with diabetes, undiagnosed diabetes as well. So one comment to Mr. Johnson about, and also for Boehringer, it is that about looking at adjacent services. For example, for us, an Asian group, that we know about the benefit of exercise, but for our population as well, though, how can we correlate the routine half-an-hour walking aerobics dances to a half-an-hour Tai Chi exercise? Does it count as exercise? Does it have an effect on reducing diabetes? We don't know about that. But the majority of our population tend to do that kind of activities that rather than going to that. And another one is about how about in one set, having the linkage of testing A1C, blood glucose, sugar, and all of this in one testing that is an adjacent services that might benefit a community or people who don't have to go back and forth with the testing at the same time.
Yeah, just have a comment. I think it was a very, very interesting comment, especially as it relates to sort of the contribution of the Asian culture on fitness. In our episodes, we incorporate some of the Asian aesthetic, especially where the core exercise is actually 10 minutes of a kinetic protocol that the 100 calories are counted within. But there's a minute before and a minute after where the kids do a warm up and a warm down, which is yoga oriented actually. And then during our episodes, at least 3 of them, we incorporate the right types of audio sounds that are taken from Asian tranquility from China actually, and we incorporate that in the beginning from the warm up and towards the end toward the cool down. And so our kinesthesiologists and psychologists have worked that into our episodes and we'll continue to have those sort of FX as a part of our program going forward.
All right. And we'll have one last question.
Thank you all for your presentations. My question is, what is working in our communities that you're integrating into the programs you have, and what are your plans for sustainability once you leave?
Okay. Good question. The sustainability part is the tricky one, isn't it? So for Cuida Tu Don, I am the only one working on it, so I am a team of 1, but we've also, because I have extended it internally and created internal champions, I imagine that should I leave, and eventually I imagine I will, that it will continue, because as we get more and more data, there is obvious proof that people want to be engaged, and as you know, again, for pharma, it's challenging, but incorporating cultural relevancy is what's absolutely necessary. And I think we're beginning to change the tide internally from that mindset of just a program or a campaign to how do we maintain that engagement. So I think it is catching on.
All right.
I would just say on that question, you've got 3 very important and different approaches. I think Dr. Egan is being modest in terms of the work that has happened in South Carolina. I think offline you should talk to him about the way his Care Coordination Institute has in South Carolina addressed disparate issues with tremendous success. And I think there's a great opportunity of replicating the work that he's done there. Coletrane, Stansbury, the work that they're doing in childhood obesity is contributing to the lowering of childhood obesity. If you look at the numbers are actually coming down in terms of childhood obesity. What I would say to you, though, really, and the message that we want to impart is that we need you to help us take these tools into community. So they're not one-off programs, but it's part of a national collaboration to really address an epidemic. When you look at diabetes in this country, it is now an epidemic proportion. If you looked at the numbers in the year 2000, about 3.3% of the American population had diabetes. It's now 9%, that's nationally. But in some zip codes, it's as high as 18 and 20% of the population has diabetes. So we need to slow up the incidence of diabetes. We need to make sure that once people have diabetes, they're getting proper coordinated care so that the cost associated with it, the assault on their quality of life associated with it is reduced. And I think that's the message that we're trying to deliver here. Here are 3 programs that are working. They're doing some really important things, but they need to be generalized.
With that, we'll in this topics discussion, I'd like to thank Mr. Stansbury, Dr. Egan, Ms. Valtierra, and Dr. Puckrein. Let's give them a round of applause.